Good afternoon. This is Fadila Shaib speaking to you from WHO headquarters in Geneva and welcoming you to the WHO press conference today. We will brief you about the WHO Strategic Advisory Group of Experts on Immunization, known as SAGE, who met this Monday, and today we will present you its interim recommendation on the use of AstraZeneca vaccine against COVID-19. Welcome all. Joining us from Mexico is Dr. Alejandro Cravioto, who is the chair of the Strategic Advisory Group of Experts on Immunization. In Geneva and in the room are Dr. Joachim Hambach, who is the Executive Secretary for SAGE, Dr. Kate O'Brien, Director, Department of Immunization, Vaccines and Biologicals, Dr. Soumya Swaminathan, WHO Chief Scientist. I would like to inform you that this press conference will be held in English only today. Welcome all. I would like now to hand over to Dr. Swaminathan to make some opening remarks. She will be followed by Dr. Cravioto. Dr. Swaminathan, you have the floor.
Thank you very much, and good morning, good afternoon, and good evening to everyone who's online. I'm Dr. Soumya Swaminathan. I'm the Chief Scientist of the World Health Organization, and what we'd like to do today is to really present to you the recommendations from SAGE. SAGE is a Strategic Advisory Group of Experts on Immunization. This is a body that's existed now for about 22 years. It was created in order to inform and develop evidence-based guidelines for immunization. And it has, over the years, developed into a very well-respected body whose recommendations are used globally. Now, obviously, at this time, there is a lot of attention on COVID vaccines, and the SAGE has so far made recommendations on the Pfizer vaccine and the Moderna vaccine. Today, we'll talk to you about the recommendations for use of the Oxford AstraZeneca vaccine. And in the coming weeks, you will see more recommendations coming out as we review the evidence from the different candidates. The SAGE working group on COVID vaccines has a very busy agenda, and in the next couple of weeks, they're going to invite the developers of different vaccine candidates from all over the world to come and present the data to them. Even if it's ongoing studies, they want to be updated on a regular basis, and this allows the SAGE and the WHO to make recommendations in a timely manner. We're also trying to work in parallel on the regulatory side, which is the emergency use listing, the pre-qualification process. So there are two sets of activities, independent but coordinated, to ensure that not only do we have the policy guidance coming out for vaccines, but at the same time we also have the regulatory work being done and the emergency use listing hopefully happening around the same time, so that countries can very quickly start the rollout of the vaccine. Now, as of today, we know that over 130 million doses of vaccines have been given to people around the world. Many countries have started vaccination programs, but we do see an imbalance between high-income countries and low and low-middle-income countries. And so these guidelines that are being released today are very, very important, because the Oxford AstraZeneca vaccine is one of the main vaccines at this point in the COVAX facility. It's going to be procured in hundreds of millions of doses and distributed around the world. And so many countries will be receiving their first tranches of the vaccine from the COVAX facility later in February. So this is an important milestone, and we hope that this will be followed very soon by the recommendation on the emergency use listing of this product, which of course, apart from safety and efficacy, also looks at the manufacturing quality and the manufacturing processes. So there are some additional criteria that are looked at before a vaccine is listed for emergency use. So I think it's an important day because it really, this is one of those vaccines which can be stored in ordinary refrigerated temperatures, and therefore it's going to be very useful for a large number of countries with different situations on the ground. So logistically, it's easier to use. And we will hear now the recommendations from the chair of SAGE, Professor Alejandro Cravioto, and then we have in the room Dr. Kate O'Brien and Dr. Joachim Hombach, and we can then open it up for questions and answers. And finally, I'd like to say that I'm sure there will be many questions on this, but this is, I think, of greater interest, this particular vaccine candidate, because of the recent data that we've seen coming out of a small study in South Africa that has raised some concerns about the use of this vaccine. So we're going to address the variants issue as well. This is something that we've spoken about in WHO, and what are the systems we're putting in place to monitor variants and make sure that we have a globally coordinated system to not only do the surveillance and collect the data and look at the evidence, but also then translate it into what happens with the vaccines. So we can talk more about that later as well. So I'd like to turn it back to you, the moderator. Thank you.
Thank you, Dr. Swaminathan. Dr. Cravioto, you have the floor.
Thank you very much. Good morning, good evening. As Dr. Swaminathan said, the Strategic Advisory Group of Experts was established by the Director General of the World Health Organization in 1999 as the principal advisory group to provide independent advice to the DG on vaccines and immunization. And for the purpose of the COVID-19 vaccines, we have set up since June of last year a group of 26 experts who have been considering all aspects that would inform policy recommendations, including values, ethics, clinical trials, and programmatic considerations. We have undertaken a three-step process for the guidance for overall COVID-19 vaccination, and this includes a values framework for the allocation and prioritization that was issued in September of last year, a WHO prioritization roadmap identifying priority groups for vaccination that was issued in October of last year, and finally, two specific recommendations for the Pfizer and the Moderna vaccine that have been previously made public. In the case of the AstraZeneca vaccine, we had a long review of the evidence, talked to the experts and the people who are directly involved with the trials, and we have come out with the following recommendations. Based on the current evidence, SAGE recommends that this vaccine should be administered in 2 doses of 0.5 milliliter each, with an interval of between 4 and 12 weeks between the first and the second dose. And given the evidence that we saw, we realized that extending the evidence between 8 and 12 weeks is the best time really to give a second dose to produce a much better immune response. So our recommendation is to use this 8 to 12 weeks interval as the main one for the application of this vaccine. In the case of the data coming from clinical trials, we have seen that there was a small participation of people over 65 years of age. However, the results of the efficacy estimate for persons up to 65 and older had a wide confidence interval, and therefore we feel that the response of this group cannot be any different to groups that are of a younger age. So we therefore, since we have identified people over 65 as one of our priority groups in the prioritization roadmap, we have based a totality of looking at the safety and the immunogenicity data, and therefore we recommend for the vaccine to be used in people 18 years and above without an upper age limit. That means people over 65 years of age should be given the vaccination. We have two groups that we look in particular. One is the pregnant women, and here, although the vaccine is safe, we don't have enough information to make a general recommendation about its use in pregnant women. However, if a woman is at risk or belongs to one of the high-risk risk groups, or is at a risk because of comorbidities, and if the woman is pregnant, we therefore see no reason why she should not be vaccinated under the guidance of the clinical practitioner that she uses for advice. That would be the same issue with women who are breastfeeding, for which we still don't have full information, but if they belong to one of these risk groups, and here we refer mainly to women who are involved in activities that put them at risk of being infected with COVID, for example, are health workers, then they should be vaccinated as well. We recommend that regardless of the person's history of whether they have had a COVID infection or not, they should also be a part of the vaccination program. We have no information to really assess how much an infection will produce a lasting immunity, and therefore we feel that it is appropriate to recommend that anybody who has had contact or not with the SARS-CoV-2 virus should get the 2 doses of the vaccine as recommended before. And we also advise governments to look at, in their own countries, of which to prioritize the group that they feel are the most disadvantaged or that have the highest rates of the possibility of getting infected and being seriously ill or dying for the start of the vaccination and the use of these products now that we have a constraint in the supply chain. We still don't recommend any of these vaccines for international travelers. We don't have enough vaccines to be able to cover that, and we don't feel that this is a group that, first of all, should be traveling unnecessarily, and second, that would require the specific protection of a vaccine. This will probably come later when the supply chain is appropriate, and also when we have other factors related to how much that will really help us to curb disease. Now, because of what Dr. Sumia was alluding to, which is the circulation of these variants that has worried everybody in the past weeks, we did look at 2 aspects of the circulation of the variants in relation to the AstraZeneca vaccine. In the trial in the United Kingdom, a preliminary analysis has shown a slightly reduced vaccine effectiveness of this AstraZeneca vaccine against the SARS-CoV-2 variant that is circulating there that we call B.1.117. And only a limited reduction in the titers of neutralization, meaning that the vaccine is still having a good effect in protecting people infected with this variant. In the case of South Africa, where the variant that is circulating is called B.1.351, the preliminary analysis using antiserum obtained from people infected or vaccinated with the AstraZeneca vaccine has shown that there is a marked reduction in the vaccine effectiveness against mild or moderate disease, and a reduction in the neutralizing antibody levels. This study was designed to assess efficacy against disease of any severity, but the small sample size did not allow the assessment of vaccine efficacy against severe infection with the SARS-CoV-2 virus. And there is indirect evidence that is compatible that there is still a protection against this severe disease using the AstraZeneca vaccine. Considering all these factors, we have made the recommendation that even if there is a reduction in the possibility of this vaccine having a full impact in its protection capacity, especially against severe disease, there is no reason not to recommend its use, even in countries that have the circulation of the variants. I will repeat that. Even if you have the circulation of a variant in a country, there is no reason that we see for now to use this AstraZeneca vaccine as indicated to be able to reduce the level of severe disease in that population. We also feel, as a final note, that there is a need to have a very strong and robust follow-up of the use of these vaccines as they are implemented in any country. The pharmacovigilance to assess its long-term safety and the impact these vaccines might have in the possibility of containing the infection are two things that are very important for us to follow up, and those will be the things that will define eventually how we have a final use for these products. We will be looking, as Dr. Swaminathan said, at other vaccines in the very near future, and we will come up with the recommendations for their use as well. I would leave it at that, and thank you very much.
Thank you, Dr. Cravioto. I would like now to open the floor to questions from the press, just reminding you that you will need to raise your hand. I will start with Sophie Mokwena from South Africa, working for SABC, South African Television. Sophie, you have the floor.
Thank you so much, Fadila. My question is around South Africa in particular. The country has already bought 1 million doses. They arrived last week. There was hope and optimism, particularly from the frontline workers who are vulnerable and also ordinary people. And now there was this information, and there's now confusion whether South Africa should continue with the vaccination using the available vaccine, even though you have this problem of the variant 501YV2. What is your recommendation as a panel? What must South Africa do? Must South Africa continue administering this vaccine, the vaccine that is available now? Or should South Africa not use it? Or are we going to be compelled perhaps to look at maybe boosting the vaccine? What is your recommendation? What must South Africa do? And what must the South African public take into consideration?
Thank you, Sophie. Your question is very well understood. And I will ask Dr. O'Brien to respond to it. Thank you, Sophie.
Yes, this question is really top of mind for people, and let me do my best to answer in as clear a way and pointing to the evidence as possible and the recommendations. I think the first thing to say is that as WHO, we have been in conversations with experts and ministry officials in South Africa. So we are conferring, providing all advice possible and in close discussions about the way forward. The important thing to remember is that the AstraZeneca vaccine is an efficacious vaccine. It has demonstrated efficacy and safety. And it is an important vaccine for the world, given the short supply that we have in vaccines. And in taking all of the evidence under advisement, this very recent evidence about this small trial that is inconclusive around its findings, albeit demonstrating a low efficacy against mild and moderate disease with no evidence to point in one direction or another on severe disease. So we have an absence of evidence from that trial about whether or not the AZ product has efficacy against severe disease, hospitalization, and death. And that is the outcome of most interest and most impact for early rollout of vaccines. We do have SAGE having reviewed all of the evidence, and this evidence was presented to SAGE on Monday afternoon, along with the evidence on variants of other types, the B117 variant as well. And we do have an assessment from SAGE that there is a plausible expectation that the vaccine will have efficacy against severe disease, albeit we don't have the evidence in hand, but there's plausibility for that being the case. And the reason that there's plausibility, it really comes from 3 lines of evidence. The first is that for all of the vaccines, there is a gradient of response going from the highest response is against the most severe disease, and then somewhat lower efficacy for moderate and then further down for mild disease. And we're starting to get evidence on the impact against infection, regardless of whether you have disease or not. So we know that there's a gradient, as is true of many vaccines. This is not unique to coronavirus vaccine. So given only evidence on mild and moderate disease, we would expect that whatever the efficacy is, it would be higher against severe disease than mild and moderate. The second line of evidence is that we know from other of the coronavirus vaccines that the correlation between the neutralizing activity and efficacy is not a one-to-one correlation. And so we are expecting more data to come in on the neutralization activity of other products that have shown efficacy against moderate and severe disease against this variant. And the third line of evidence is on the T-cell responses. And remember that there are different ways that the immune system responds to vaccines. One is by producing antibodies, but another component of the immune system are the T-cells. And the evidence that was presented to SAGE provided a view that the maintenance of the T-cell response would be quite strong against this variant. So it's really the guidance that SAGE is coming with is to recognize that we have limitations of the data around exactly what to expect with this vaccine relative to severe disease, hospitalization, and death. But in its full nature, the advice from SAGE and taken on board now by WHO is to proceed with the vaccine even in the setting of variants, with countries taking into consideration their own specific epidemiologic situation, the access that they have to a variety of different products, and to tailor that decision-making for each country. The intention, as we understand it from South Africa, is to proceed with the use of the AstraZeneca vaccine in the context of collecting in a very dedicated way and a well-designed way, collecting the kind of information that is needed in order to fill in some of the gaps in information around severe disease for this product with the variant that is circulating. And we will be doing everything possible to support South Africa in any way we can around the design of the evaluations of the vaccine. So the pause that has been put in place to allow time in order to design what those evaluations will look like is an important pause so that they can be best designed to get the kind of evidence that would allow an ongoing review of the vaccine and the way it's being deployed in different countries and different settings around the world. So that's the reasoning behind the recommendation from SAGE and that recommendation to WHO, which has been accepted, and the advice, generally speaking, to countries about how to address the use of the vaccine and the variants. So let me stop there and just see if either of my colleagues, Dr. Humbach or Dr. Swaminathan, want to add anything further to that.
Very quickly, just to say that, just to re-emphasize that the decision in South Africa is to roll it out, but in a way that you're collecting evidence and data so that that can inform the future rollout. So some of the headlines we saw in the media were, that they're going to stop using this vaccine. That's not accurate. And so I think the way that, Kate just explained it, it's a phased rollout of the vaccine. The other quick point is that some countries have, a choice of multiple vaccines that they have already purchased, and in those situations, countries can actually make decisions, because from what we know of these different vaccine candidates, you could use them for one subpopulation. Introduce a vaccine, and this vaccine may be the first one. It's certainly the benefits, will far outweigh the risks. And the last point I want to make is that the detection of the variant in a country does not mean that that is the predominant circulating strain. So unless there is good genomic data from a country, South Africa has a significant amount of genomic surveillance. So they've been able to track over time the displacement of the previous variant with the new variant, the 501V2, and which now constitutes 90% of circulating strains. But in many other countries, the situation may be that with very limited sequencing, we've been able to detect this variant, but we don't know the spread. And therefore, we have to be very cautious in making decisions based on very limited data. And I think one of the messages clearly is the need for improving genomic surveillance and initiatives like the African Pathogen Disease Initiative that the Africa CDC and Africa WHO are doing jointly to expand genomic surveillance across the continent is going to be very important in the coming days.
Thank you, Dr. O'Brien. Thank you, Dr. Swaminathan. I would like now to invite Christian Ulrich from German news agency DPA to ask the next question. Christian, you have the floor.
Thank you, Fadela. This is also a question on AstraZeneca. Are you not afraid that people who will be vaccinated with this vaccine that might not be as efficient as others, that they would feel a false sense of security and let down all the other measures and might, in that case, make the situation worse than it is at the moment?
Thank you, Dr. O'Brien.
This is an extremely important point, not only for any particular vaccine, but for the entirety of the vaccine program that is rolling out worldwide in countries everywhere around the world. The issue of whether or not a person who has been vaccinated can take their foot off the pedal and stop using a mask, stop all the other interventions that we've been communicating for the whole of the pandemic, hand washing, now physical distancing, avoiding congregating in large groups of people. Those interventions need to continue for individuals who have been vaccinated and for communities of people as the vaccine is rolling out. And the reason for that is several-fold. The first is that we have evidence on whether or not these vaccines and the magnitude of how much they protect against disease. That is what the efficacy trials were designed to do, and these are the efficacy results that have been so widely communicated and I think are being well understood by people in countries around the world. What we don't know about these vaccines is the degree to which they protect against becoming infected. And as we all know, you can be infected and have no symptoms. Either you're before the development of your symptoms, or in some people, they become infected and don't develop symptoms at all. And yet any of those people can transmit the infection to somebody else. So until we have the evidence from the studies, and they were designed into the studies, but we don't have the results of those data yet, we are recommending very strongly that people maintain all other interventions, masking, hand washing, avoidance of a lot of contact with other people, because for several reasons. First of all, no vaccine is 100% protective in 100% of people who receive the vaccine. We've seen that the efficacy results are very strong, especially for hospitalization and death, but none of them are 100% effective against all elements of disease. So even if you are vaccinated, you still have some risk of developing disease, even if it may be of a more mild form. And you certainly are at risk of still becoming infected, whether you know it or not, and transmitting it to somebody else. So for these reasons, not for any particular vaccine, but frankly for all of the vaccines that now have evidence around their efficacy, being vaccinated is not a reason to stop doing all of those things. In fact, it's ever more important that everybody is undertaking the interventions with ever greater intensity. And the reason I say that is as we roll out these vaccines, they can only be effective to the degree that, that the viruses that are circulating are going to be sort of knocked down by the vaccines. The more the viruses circulate, the more transmission there is, the more chance there is that there's a variant that actually develops that starts to have less impact by the vaccines. So now is the time to actually intensify all of the interventions that we have while the vaccines are rolling out to assure that these amazing products that we have now, the scientific achievements, actually can deliver the impact that they were designed to deliver.
Thank you.
I had just one sentence, and that is that if you're a healthcare worker in a country and the country is rolling out a vaccine, please take it. Don't compare and wait for something better to come along. A vaccine now is much better than waiting for something potentially that may come down the road after 6 months or a year. So anything that's being approved by WHO, that's being distributed by COVAX, that's available in the country, or that's approved by regulatory agency, you know, and being made available, please do take it.
Thank you. I would like now to invite Catherine Fioncon-Bokonga to ask the next question. Catherine, can you hear me?
Yes, thank you, Fadela. Good afternoon to all of you. My question is regarding the surveillance and the collecting of the data. Is there a mechanism? Because Dr. Soumya Swaminathan spoke about it as her colleagues. Thank you.
Thank you. Yeah.
Thank you. That's such an important question. You know, this is the first pandemic where I think we've had so much information on the virus and on immunity and on the science. I don't think there's any other virus that's been so well studied by so many scientific groups around the world. One of the really remarkable things have been the availability of genomic sequence data on this virus. Starting from the very beginning, on the 10th of January, we received the first genome sequences from Chinese scientists, which told us that this is a new virus closely related to SARS-CoV-1, but a completely new virus, and it was then later on named SARS-CoV-2. And now we have almost 500,000 whole genome sequences in public databases like GISAID, like GenBank, and there are thousands of scientists working around the world collaboratively to analyze these data. So from the beginning, we've been watching this virus and we've learned, all viruses mutate or change, especially RNA viruses. Now this particular virus actually has been changing or mutating much slower than other viruses like HIV, like flu. So in a way that's been reassuring. We were tracking these changes right from the beginning. There was a mutation that appeared in February, March, the D614G, that quickly became predominant across the world, and there were early reports that it's much more transmissible. So this is a natural evolution of viruses, so we are not surprised. What is recently has been of concern, of course, is that some of these mutations in the spike protein are actually acting to prevent antibodies from binding as effectively to the virus. So the virus is able to get around the antibody and still go and bind to the cell receptor. But the scientists are tracking this, and they're finding ways of how we could change the vaccines as well as monoclonal antibodies and treatments. So we have, for the genome sequences, we have public databases, we have a very good system. I mentioned the virus evolution working group that WHO had set up in June last year that's been tracking this, and we work with all our partners. We work with CEPI, we work with this network of labs. We are now setting up also groups that will be able to periodically provide some guidance on the need for changes in the vaccine strain, similar to what we do for influenza. We have twice a year the advisory committee that informs which strain of flu should go into the vaccines for the following year. So maybe a similar mechanism is going to be needed for COVID-19, and we're already setting that up. In terms of data on other parameters, like the safety of vaccines, the efficacy, the effectiveness of vaccines, and the impact that the vaccines have in countries as they are rolled out, this is very important also, to do well-designed studies which can then also be fed up so that there's a platform and a database that's collecting all this data. So we have a meeting tomorrow that's going to discuss the various methods that countries should use to collect data, both from, going all the way from randomized trials of testing different vaccines in combination, or looking at different durations between the first and second dose, or looking at one dose versus, a delayed booster. There are different designs. And then observational cohort studies, as is happening in countries like Israel and the UK. We're learning as vaccines are being rolled out, and the impact on hospitalizations, the impact on transmission. As well as on the safety side, we're going to develop a platform that will collect active monitoring of people who are getting the vaccine, so that we keep learning about the safety as well. So it's important to have all of these data sets. It's a lot of data and a lot of work to set up these platforms, but the WHO is working with groups around the world to do this. If you want to add anything to that, Kate?
Yeah, maybe just to add some very few words. I mean, you have noted, obviously, that the recommendations are called interim recommendations, and this is actually reflecting the fact that we are, of course, expecting that more data are coming in relation to the AstraZeneca vaccine. There is actually a large clinical trial still being conducted in the United States. And then, obviously, as it was referred to, the assessment of the impact, of the effectiveness, and of the safety through various studies, observational studies, or other really more planned studies will be extremely important. So we are very active in this field. There has been a specific protocol developed for conducting these studies. There is an active follow-up on the safety signal through the Global Advisory Committee on Vaccine Safety. And so this is information that we are obviously scrutinizing, also in relation to looking whether there is any update needed in relation to our overall positions and recommendations. And obviously it was pointed out by Professor Caviotti in the beginning that there is a couple of population groups where we still do not have many data. Pregnancy was mentioned, but there is a couple of other groups. HIV infected individuals. So also these are data that we are expecting to obtain through the rollout and through observational or small dedicated studies.
Thank you. I would like now to invite a reporter from Politico, Carlo Maretuccelli. I hope I pronounce well your name. Carlo, you have the floor.
Yes, hello, Carlo from Politico here. Thank you for taking my question. I had a question just regarding the recommendation for the over 65 age group. It was mentioned by Dr. Cravioto that this was based on a wide confidence interval. I just wanted to know if you could explain what was meant by that. And then I also had a second question, which regarded when we might expect a formal emergency use listing. Thank you very much.
Dr. Cravioto, do you want to take these questions?
I think about the confidence intervals, I would like Dr. Joachim Hombach to answer that, please.
Okay, happy to do so. Yes, this is correct, and we have obviously discussed this at the SAGE committee. The reason why there is a very large confidence interval around the efficacy estimate for people above 65 is a number. There were relatively few older people enrolled in the study. They were enrolled also at a later point in time, so less data have accrued, and it was also observed that apparently the people in this age group did a big effort to shield themselves from COVID, so the attack rate in this age group was also relatively low. All this resulted then in relatively small numbers and then a wide confidence interval. There were a few other aspects that we looked at in relation to the above 65 years of age. Another thing, and it was mentioned by Dr. Cravioto, is that the efficacy of the vaccine is higher when the second dose is administered later. The administration of the second dose for the people above 65 was, however, in a relatively narrow time window of 4 to 8 weeks. And so this is also something that needed to be taken into consideration. So you would expect actually to see a higher efficacy if you administer the vaccine according to our more recommended schedule, which is 8 to 12 weeks between the two doses. So these are all factors that have been that explain that the vaccine efficacy estimate for older people in the data that we have available is relatively modest and not very precise. However, we have also looked at additional data, in particularly on the immunogenicity, and both antibodies as well as cell-mediated immunity. And what you could see here is actually that the immune response in people above 65 is almost the same as in younger people. And this makes us very confident that this is a vaccine that is actually protective and well protective in people above 65 years of age.
Dr. O'Brien?
Just one other point to add to the excellent response from Joachim. In addition to the evidence that we saw on the performance of the AZ vaccine in those over 65 years of age, SAGE also considered modeling data. And modeling data revealed that even when the efficacy drops down, a hypothetical efficacy drops down to as low as 10% efficacy, it's still the right thing to do to immunize older adults with a low efficacy vaccine because of the high risk of severe disease and mortality in that age group. So the evidence shows that the efficacy in older people, as was explained by Joachim, we see very strong immunogenicity, very comparable to younger adults. The efficacy estimate itself is a strong efficacy estimate, but with this uncertainty bound that does cross zero. But even if the efficacy were substantially lower than even what was measured, it's still the right thing to do to go ahead and vaccinate older adults using a product like this. And then I just wanted to address the emergency use listing question. I'm sure you understand that this is a product that is actually being manufactured in a number of different locations around the world. Those are referred to as nodes. The product that is being primarily managed by AstraZeneca, and then a product that is being managed by the Serum Institute of India. So those are two separate EUL processes. And both of them are in their last stages of evaluation, and decisions, meetings will be held on February 12th and 15th to consider each of these. And so we expect a decision to come out in mid-February on each of the AstraZeneca managed product and then the SII manufactured product.
Thank you. I would like now to invite Brazilian journalist Ana Pinto from Folha de Sao Paulo to ask the next question. Ana, can you hear me?
Sure. Hi, thank you. My question is about the P1 variant. I understand that there is no data on the impact of the AZ vaccine on the P1 variant, the one discovered in Brazil, right? But I would like to ask that, given the fact that this P1 variant has the same mutation of concern, the E484K, which is related to the ability of the virus to escape the antibodies. My question is if the same results should be expected, the same results encountered in South Africa should be expected, and if there should be more studies also about the AZ vaccine on the P1 variant to orient, to guide the policies in Brazil related to the protection of the people of the countries where there are this variant. Thank you very much.
Thank you, Anna. Dr. O'Brien, you have the floor.
Yes, so just confirming that indeed you're right, either the serologic evidence or clinical evidence on the P1 variant are still in development. We know that first of all, the AZ product, as we all know, has a clinical trial ongoing in Brazil, and so cases are accruing, and we do expect that there will be evidence that will come forward around the interaction performance of the AstraZeneca vaccine in relation to the P1 variant, and that there would be serologic data as well, neutralizing titers to contribute to that evaluation. I think we are so in the early stages of understanding what any specific change in the virus means for the performance of one or another of the vaccines or the vaccines as a whole. So the speculations about what might be seen, especially speculating around P1 relative to what has been seen for B1351, where we've already appreciated that we have such limitations in the evidence around the B1351. So I think it's probably best to let the data speak for themselves rather than speculating on what the data might show, because we are so, as a world, in this learning phase with the vaccines and with the viruses. But we do need to be prepared for doing comparisons, undertaking surveillance so that we have a clear understanding of what the viruses the variants of the viruses are doing and how far and wide they are transmitting. And some of these variants may result in the virus being less fit. So it's not always that a variant actually is to the advantage of the virus. Some of the variants actually are either neutral for the virus or make a virus less able to cause infections in people. So we're in early days on P1 and its relationship to each of the vaccines that has demonstrated efficacy at this point.
Thank you. Let's move now to India. I would like to invite Ashwin Bashing from Observer Times to ask the next question. You have the floor.
Thank you for consideration. As it is report that the highest mortality rate of the COVID-19 disease occurred due to cytokine storms. My question is, what reports WHO have for over-response of immune system called cytokine storms in COVID-19 patients? Is this considered in AstraZeneca AZ-122 vaccine approval for emergency sanction around the globe?
Thank you, Dr. Swaminathan.
Thank you. Yeah, that's an interesting question. So the primary endpoint in the AZ vaccine trial was symptomatic COVID-19 disease. So you had to have a positive PCR test with one or more of symptoms. There's a long list of symptoms. And then in most of the trials, they've tried to classify people in, if they got the disease, was it mild, moderate, or severe? The definitions vary a little bit between, the different vaccine trials, but WHO has a clinical definition scale. So when companies use that, then it's easy to compare. And then, of course, looking at hospitalizations and death, these are the endpoints, that were measured. There may have been more detailed immunological studies done, like the cytokine storm, for example, that you talk about. But I think the focus of the vaccine trials are really on looking at the immune response to the vaccine, both in terms of the cell-mediated immunity and in terms of the antibodies, what we call the humoral immunity. And one of the goals that we need to come, again, as a global community, we need to decide is what are the correlates of protection? What are the surrogate markers so that you don't have to do in the future by looking at rates of protection, but we need to define what immunological endpoints we are going to use for that. So that's something that's still being worked on by scientists. So the cytokine storm really is something that occurs when somebody gets severe COVID-19 disease, and there are many clinical trials going on to look at treatments for treating somebody who's got the disease, immunomodulators, anti-inflammatory drugs, and so on. But that's not the focus of the vaccine trial.
Thank you. Dr. Hombach, you have the floor.
Yeah, maybe just to add a small element. I mean, you're right that there is this concept of the cytokine storm in severe disease. And what I think is believed is that a certain type of immune response, a so-called more Th2 type of response, is certainly favoring this type of immune reaction. So that is something that the vaccine developers have looked into, because there is this concern eventually of enhanced disease, also that has been discussed, even though there is absolutely no indication that it actually occurs for SARS-CoV-2. And so there have been studies with this vaccine that have shown that the immune profile that is actually elicited by the vaccine is a so-called Th1 profile, which is not expected to be associated with this type of immune response and immune pathology. And this has also been shown in non-human primate studies, challenge studies, where no signs of immune pathology have been observed. So I think from that perspective, the issue has been addressed in the study of this vaccine.
Thank you. I would like now to invite Gunilla von Hall from Svenska Dagbladet, Swedish journalist, to ask the next question. Gunilla, you have the floor.
Thank you, Fadela. Can you hear me?
Yes, very well. Go ahead, please.
Thank you. I wonder, it concerns people over 65. what do you say then that the protective, the efficacy of the vaccine for people over 65 years is? What is your estimation? And then I'm a little bit puzzled because why are you coming with this? I know it's preliminary, but why are you doing this instead of waiting for the American study, which will come any day? And is much more in a broader group with more people over 65. And lastly, what is your message to, sorry, many European governments that are not recommending, have decided not to recommend AstraZeneca's vaccine to people over 65, among those France and Sweden? Thank you.
Thank you, Gunilla. Dr. O'Brien, you have the floor.
Yeah, thanks so much. Again, we point to the evidence that comes from the efficacy trial and the estimates of the efficacy. Again, I'll repeat what the confidence intervals are on that, but the estimate of efficacy, depending on whether it's looked at after 1 dose or after 2 doses, is in the range of 52% to about 56%. And the confidence intervals on that go up to as high as 85%. And I mentioned, I think Dr. Cravioto mentioned already, and so did Dr. Humbach, that the lower bound of the confidence interval goes below 0. So those are the efficacy trial results. They, first of all, doses were not administered in the extended interval strategy, which we also have evidence shows that with a longer interval between the 2 doses, you get better efficacy. And then the second point is that evidence is accruing from the UK as the vaccine has been rolled out. There are additional cases that are occurring, and we are expecting soon to have some effectiveness estimates among older people. The question was, why aren't we waiting? Why don't we just wait? Why don't we constrain the use of the vaccine to those under 65? And there are a couple reasons that I'll just emphasize again. The first is that even at these values, so we have strong confidence from the comparability of the immunogenicity data that there's no reason to expect that efficacy is substantially compromised in older people. The second is that we do have efficacy estimates that confirm that there is significant efficacy for those over 65. The third point is that the additional evidence we certainly are going to look at, but there is urgency to provide recommendations now at the present time when these vaccines are available at hand and ready to be rolled out in a large number of countries, and countries are relying on our best advice of how to use vaccines. Now, some countries may have a choice of products to use and may choose to use different products in different ways, either because of operational characteristics. Some vaccines that require ultra-cold chain, like the Pfizer vaccine, may be difficult to deploy in some settings. With multiple vaccines in a program, there may be the choice to preferentially use one or another for different uses. But there's no reason, especially because the over 65s are at the very highest risk of severe disease and death, that a product that has significant efficacy, it should go ahead and be used. That is the priority group, and so there's no reason to constrain the AZ product from a general recommendation in the view of SAGE and adopted by WHO for an age criteria, while we're also learning and accruing more evidence. The US trial, the multi-center trial, we're waiting with great anticipation. Our understanding is that those results are not expected for at least until into March. And so it's not possible, given the evidence that we have at hand now, the SAGE assessed that the preponderance of evidence weighed in favor of the age criteria for its use.
Thank you.
If I may add, Kate,
Please,
Yes,
Alejandro,
please
yes, go ahead.
I think one of the considerations that SAGE is making is the need to stop severe disease and mainly people dying, and withholding a recommendation for a number of weeks, waiting for more information when we have enough to make a recommendation, I think would not be appropriate. We have thousands of people dying from the infection in many countries of the world daily. And I think anything we can do to use a product that might reduce that is totally justified, even if the information is not as complete as we would like. Thank you.
Thank you, Dr. Capioto. I would like now to invite Jamie Keaton from Associated Press to ask the next question. Jamie, you have the floor. Jamie?
Can you hear me?
Yes.
Can you hear me?
Yeah. Please go ahead.
All right, thank you very much. I didn't know if I was unmuted. Yes, thank you very much. I guess this question is for Dr. O'Brien. Well, I want to just get a sense as to how concerned you are that South Africa, which of course is a reference for many developing countries, is expressing doubts about the AstraZeneca vaccine, which really is one of the most important parts of the COVAX project. How much is that factored into your thinking? And if you could just maybe elaborate a little bit, do you have any thoughts about whether or not there more effort should have been done to diversify the portfolio with, say, Pfizer's, to make a stronger effort to get behind the mRNA vaccines earlier, whether or not there were cost and cold chain issues? Thanks so much.
Thank you, Jamie. Dr. O'Brien?
I think probably the first thing to say is we're in a very dynamic situation right now, and we will all be making adjustments to any recommendations as evidence continues to accrue. South Africa, every country is responsible ultimately for their own decision-making about their own particular circumstance and epidemiologic situation, and also under consideration of the stage of the pandemic, the priority populations, the product availability across the range of products that are out there. And so I think it's not appropriate really to take a kind of global view about the recommendations for countries to consider and then apply specific countries' decision-making. As we described, we're in really close conversations with South Africa. They are going to be using the AZ product and taking this pause to be able to assess exactly how to best design an evaluation so that more information can be added to this puzzle that is an incomplete puzzle at this point. There are a large number of doses of the AZ product and other products in the COVAX facility. It is a diversified portfolio, and it is increasingly becoming diversified. Part of the issue around the portfolio vaccines for any country's bilateral arrangements or COVAX or any other regional portfolio, it's not just what's in the portfolio, it's also about when the doses come. And so we do have, for instance, the new J&J results, the new Novavax results, but those products are not yet authorized, and the timing of their availability from a supply perspective, they're not all evenly distributed over time for access for any country. So we really have to work with what we have at hand now in the portfolio, in the toolbox, available to countries, and make our best recommendation on the evidence that is available about how to best use those tools. And we have fantastic tools. This new evidence is important, but it's really inconclusive. And so the recommendation from SAGE is to continue with the deployment, especially because the vast majority of countries are facing a pandemic with strains of the virus that are not this variant, and even for countries that have this variant in the country, it's not the dominant variant. So there's still incredible value to be had, even if it would be true that the efficacy of the AZ product against the B.1.351 variant is has strong limitations to it. But we don't know that. We don't know whether or not what that efficacy is against severe disease for the B.1.351. So I think the diversification of the portfolio is an important question, and it has a diversified portfolio base. The mRNA vaccines, the decision-making around having the mRNA vaccines is also a portfolio management issue around the price point. Obviously, price determines how many doses can be procured. There are trade-offs there. The ultra-cold chain and the ability of countries to want that vaccine or to be able to handle that vaccine in a broad rollout. As you know, now we're deploying that vaccine imminently. Countries have been announced that will be getting that vaccine in the first wave. And those doses will likely be very constrained to use in capital cities where that ultra-cold chain can largely be managed. So there are these trade-offs, and that results in numbers of doses, type of product in the COVAX facility.
Thank you, Dr. O'Brien. I think I will take one or two more questions. I would like to invite Stephanie Nebehe from Reuters to ask the next question. Stephanie, you have the floor.
Thank you. Yes, a question follows on from that, please, for Reuters. The South African health minister has said today that they're indicating they're trying to trade some of their AstraZeneca doses. And he specifically mentioned that there had been talks with the COVAX facility and with the African Union. Can you comment on that, please? Thank you.
So the COVAX facility obviously wants to work with countries to make it do everything possible to facilitate the rollout of vaccination. Countries can express preferences for some vaccines over others. They can opt out of vaccines. So I think it's perfectly possible for South Africa to have these discussions with the COVAX facility. South Africa already has vaccines which they directly purchased. So the first batch of AstraZeneca vaccine which is available did not go through COVAX. South Africa is also one of the countries that will receive Pfizer vaccine in the first wave from the COVAX facility. And then there are subsequently shipments of the AZ vaccine that have been planned. So I think it's possible to discuss this, and we should, as I said, we're open to this the discussion with countries. And as time goes on, there will be not only more volumes, but also a broader portfolio of vaccines. We're very soon expecting to get the data from the J&J as well as from the Novavax vaccines, both for policy recommendations and for the emergency use listing. So as the months pass, there's going to be a wider variety of vaccines. But as Kate mentioned, there are trade-offs between these different vaccines. Obviously, the ultra-cold chain requirement for some of them, single dose being an advantage for a number of countries, as well as the efficacy in different age groups or other subpopulations. So I think as time goes on and we learn more, but I think the important thing is that right now it's important to get the vaccines out and the high-risk groups getting the vaccines so they're protected. As Dr. Cravioto said, the pandemic is raging. We need to prevent deaths. We need to protect our health workforce, protect the health system so that they can then serve others. So that should be our priority now, using the vaccines that we have. And then as time goes on, the recommendations will get more refined. And I think the other important message is that we need to learn, and there needs to be a body of evidence that we consider, and we tend to react now to every finding, every study, regardless of, whether it was large enough, whether it was robust enough, whether the evidence was strong enough. This is not just for vaccines, but for treatments as well. We've seen this over the last year, right? We've become euphoric one day, and then we become depressed the next day. So this is where, we have to be a little patient. Let the evidence accumulate till we can make a decision based on the data, and that's exactly what SAGE will do. Thanks.
Maybe I can just add a couple of things. I do want to emphasize, both in relation to this question and the previous question from Jamie, is that there are actions by different sort of partners along the chain, and I think we really want to emphasize also the actions of manufacturers, that in order to achieve speed here and achieve access, what is absolutely critical, in addition to the things that we've talked about, the data and country decision making, is that manufacturers have responsibilities here as well, and they can help to make this global access easier. And the ways that they can do that, number one is prioritizing the submission of data to WHO for emergency use listing. We are unable to move on EUL unless we actually have the data to evaluate. We do expect that manufacturers will make that a priority as some of their, after the submission for the first authorization that allows the marketing of the product, we would really ask that manufacturers make WHO EUL their next stop, and that consultation be happening before they're even, while the data are in development, so that there is a readiness and a preparation to know what will be required and to be able to submit it. And the second is around prioritizing the COVAX facility for deal making. That this is the only global mechanism that we have for fairly and equitably distributing vaccines, so that we can assure that the highest priority groups in all countries are served, and doing that before serving lower priority populations in a limited number of countries. We've been really going at this message that there are now, we're at over 130 million doses that have been distributed and administered worldwide, and the vast majority of those doses are going to just 10 countries. So the importance of products being considered by the COVAX facility, getting into the portfolio, if there's an advantage for the portfolio in its diversification and its supply distribution, just cannot be overemphasized, and the willingness of manufacturers to engage in discussions and in negotiations. Discussions, of course, on the EUL side, submitting data for the policy process, which we're talking about here, and for undertaking assessment of deals with the COVAX facility. Those are things that manufacturers can do to make things go faster, make things go fairer, and make things more accessible. And so I think we're just calling on all actors to do the thing that's in your remit and your ability to assure that as a world, we're getting to the impact that these amazing scientific achievements hold promise for. But unless we have solidarity along with science, they're not going to get their maximum impact. Soumya, I think you wanted to add something. No? Okay. No. Thank you.
Thank you all. We have gone over 1 hour. In fact, it's 1 hour and 15 minutes. So I think it's time to close this press conference unless we have any final comment. I think I would like to thank journalists who are following us. And if you have any follow-up question, don't hesitate to contact the media team of WHO. Thank you all for your participation, particularly to Professor Caviotto from Mexico. And just to let journalists know that we have posted the interim recommendation on the web, and they were also sent to the media list before the start of this press conference. You will be receiving the audio file just shortly after we end here. And see you Friday. Thank you all. Thank you all, and see you next Friday.